Hello, welcome everyone. Great that you've all joined us today. I think we've got a huge crowd. We've already had loads of fantastic questions. This is the Value-Based Healthcast, brought to you by the Welsh Value in Health Centre. I'm Nick Wilkinson. I'm a paediatrician who specialises in ambulatory care, principally around rheumatology and chronic pain, and set up services. So this is a real interest to me.
And I'm David Hanna. I'm also a paediatrician. This is not a paediatric podcast, but I happen to be a paediatrician. I work in the emergency departments in Cardiff and Vale, and I've got interests in service development, transformation, quality improvements, and more recently, value-based healthcare. So
value-based healthcare is really about delivering the outcomes that matter to people, the resources available to us. It requires a lot of collaboration between clinicians and patients, and using clinical, financial, operational, and population level data to improve on care. And I think that will really come out today.
And so every month what we do is we ask a question about an area of value-based healthcare, and we have a conversation in a sort of a podcast format. Because of the way Teams works, it automatically turns off your video and your mic when you join, but we do want you to get involved. So if you've got any questions as we go along, then just pop them in the chat bar and we'll do our best to answer them, or put them to our guests. And if we don't get to your question during the episode, we'll go away and find the answers and come back to you. But please get involved. We do want you to participate, and we want to hear what you think.
So if we're looking at down and we're potentially looking at our phones, it's only because we have guys, so Brooke and Sam off screen, collating your questions and sending them to us. So any apologies for that.
So Nick, before we introduce our guest, I thought it might be helpful just to remind ourselves why we picked back to basics for our topic today.
And I think there's no one better to talk about this than Sally, and that's why we've started off this year with Sally. I
mean, so one of the things I noticed from the previous sessions we've done is that there's a huge range of experience in terms of value-based healthcare amongst the audience.
Yes.
Some people who are very seasoned professionals who are doing this a long time, and others who are brand new to it. So, you know, I felt it was about time. We talked about data previously. We talked about palliative care. We talked about patient-centered care and proms. It was probably a good time for us to bring it back to basics. And yeah, as you say, no one better to do that than Sally Lewis.
And I was really interested in her recent paper that was just at the end of last year, and hopefully we'll bring out some of the points that she's raised in that paper. So.
Fantastic. Well, without further ado, we'll introduce Sally. So Sally Lewis trained as a GP and has frontline experience of primary care at its most challenging. She entered a career in medical management in 2011 and was appointed to Assistant Medical Director in an Iron Bevan University Health Board in 2014. But since 2018, Sally's been leading the National Value-Based Healthcare Programme in Wales, which is now part of the World Economic Forum's Global Coalition for Value-Based Healthcare. And she's an honorary professor at Swansea School of Medicine. So it gives me great pleasure to introduce Sally. Sally, take it away.
Thanks, Dave. Thanks, Nick. And hi, everyone. Really good to see so many people on the call. It's a funny thing, you know, speaking in your own backyard is way more nerve-wracking than speaking anywhere else in the world. So I'm feeling the nerves today, actually. So I've set this challenge by Nick and Dave and the team to bring us back to basics. So I haven't got stacks of slides because I know you've sent loads of questions through. So I've just got 8 slides in 2 sections. And in the first section, I'm going to talk about a very brief recap as to what value-based healthcare is and what it means to us in Wales, and how I got interested in it, really, and why I think it's not just important, but actually essential for transforming healthcare services in the way that we're all trying to do. And then in part 2, trying to bring in some examples and also illustrate some of the work that we're trying to drive through the Value in Health Centre. But it's meant to be a conversation, I think, so hopefully we'll have lots of chat along the way. So let me do the most nerve-wracking bit of all, which is always the sharing the slides bit on Teams. We've all been there, haven't we, with this?
Easier. And it never gets any easier.
Okay, good. So I think we've got it. Brilliant. So value in health, what is it? Why is it important? And what do we need to do? So as we're all trying to transform healthcare services, it does feel like we're Sisyphus, doesn't it? Pushing the boulder uphill. And it always feels like that, and it probably always will feel like that. So to me, value-based healthcare has always been a lens through which we can look at the system and maybe give us a beacon of hope that we can achieve some of the things that we're trying to achieve. So the definition that's probably most applicable to the Welsh context is this one on the right, which is the equitable, sustainable and transparent use of the available resources to achieve better outcomes and experiences for every person. So if you look at the literature and you try and get a definition of value, you'll get lots and lots of opinions and very hard to get consensus, because of course what we value as individuals can vary enormously. Does it just mean cost cutting and the cheapest form of care? No, of course not. It does mean that we're trying to get, in the Welsh context, the best outcomes that matter to people. So achieving people's individual outcomes, meeting their goals. So that's a little bit more than just standardised outcome measurement with the resources that we have equitably. So we're trying to not leave anybody behind, not leave anybody out, accepting that we have finite resources and trying to do the best that we can with what we've got. And that's what it's all about, really. And trying to manage that tension as well, I think, between achieving individual wants and needs and population wants and needs. And there's always that tension there, isn't there? So value-based healthcare isn't new in many ways, and it stands on the shoulders of lots of movements in medicine around the world that tap into the notion that all is not well in healthcare, that we have escalating costs that are eye-watering, actually, and point to all healthcare systems being completely unsustainable in the next 10 to 15 years. So politics is not the only thing in terms of funding and how we approach healthcare delivery. Some of the problems that we are experiencing are very much because our systems are just not designed to meet the needs of our population now. A lot of them are still operating very much in the way that they were 70 years ago. And of course, people are living longer but not necessarily healthier lives, so we have a growing number of people who are living a long time with chronic conditions, and we are doing more things to them with them, so the costs mount. So we need to think about new models of care and how we achieve people's outcomes and a good experience of healthcare whilst it's still being sustainable. So some of those other movements around the world have been, of course, Prudent healthcare, which was my entry really into value-based healthcare, I guess. Prudent healthcare in Wales, which looked at very much co-production with patients and the public, equity in terms of care for those with the greatest health needs first, doing only what is needed and doing no harm. And that's really important because a lot of evidence-based protocolized medicine pushes us into activity which isn't necessarily always what people need, and reducing inappropriate variation, of course. I don't like inappropriate variation, actually. I'd rather say unwarranted variation. Realistic Medicine in Scotland picks up very, very similar themes. Choosing Wisely International came from Canada and is really just about reducing low value care, which is important, but kind of on its own. I'm a bit, it's a bit reductionist. So important to reduce low value care that's not improving people's outcomes, that is, but is costing resource. But also coupling that with, well, what do we need to do instead then? And my personal favourite is, without a doubt, Slow Medicine from Italy, which has been going longer than the others and is typically and flamboyantly Italian, and involves lots of talk of slow food and slow love and lots of other things like that. So value is really standing on the shoulders of these other movements, I think. So how have we arrived here? Well, I'll tell you how I arrived here. And I think we all have personal experiences and professional experiences that shape who we are, what we believe in, and then what we strive to do in our personal lives and our professional lives. And we have lots of those. So I'm going to pick two that probably led me into value-based healthcare and why I think it's so important. So this is the first one. This is my old surgery, Glanreed Surgery up in Beaufort, Ebervale. Where I was the senior partner, and I joined this surgery in 2005. And working with the patients that we had in Glanreed and seeing the aftermath, I suppose, of how health in an ex-mining community was impacted by a range of socioeconomic and other factors, I became really frustrated and interested at the same time as to why resource allocation across the system was so imbalanced, why we were failing to meet the needs of our patients in the ways that we would wish, and why we had failed to tackle inequalities in health. So Julian Tudor-Hart wrote the Inverse Care Law paper and published it the day before I was born. I'm not young, right? So we haven't tackled that. In fact, it's got worse. So I got really interested in finance and the structure of the organisations that deliver healthcare in Wales and further beyond when I was working at Glanreed Surgery. And I was really interested in how we could do that differently. And that led me into some work with the Health Board and subsequently on into Prudent Healthcare, though I didn't know that that's what it was going to be then. I just want to give you an example of that allocation problem. So if you take chronic obstructive pulmonary disease, COPD, a chronic respiratory condition that affects often smokers, but not universally smokers. And there are a range of treatments for COPD, which is a very disabling condition. Those treatments are not particularly effective, to be honest with you, mostly inhalers when we're prescribing in primary care. But what really benefits people with COPD and actually a lot of other chronic conditions are not the drugs that we give, but actually the support for self-management and that real support to people to manage their condition and lead their best lives and have the best quality of life when they have a condition. So yes, it's important to look at prevention, but how do we really support people when things go wrong? And the system's really poor at investing in interventions like that. Brilliant at prescribing and buying new drugs and devices and interventions that are technical, but really poor at doing this other stuff. So I was really interested in how we could start to resolve that type of problem. Okay, so the second example, this is my dad. So my dad died 7 years ago of heart failure, essentially. And this is a story of person-centered care and why evidence-based medicine doesn't give us the whole answer. So my dad had heart failure. He had advanced heart failure, had heart disease for many years, but he also had sort of mild, becoming moderate vascular dementia. So as Dad's heart failure got worse and he started to have fairly frequent hospital admissions, and I could see objectively, you know, that he was getting worse. He had an admission when he was staying with my sister up in Leeds, and he was found to have sort of intermittent arrhythmias, and they thought that he was reaching a point where he would benefit, or rather his heart would benefit, from an implantable device. So an implantable device in heart failure, which synchronizes the beating of the heart and helps it pump more efficiently and can improve the quality of life of people with heart failure in the right person. And sometimes these devices also actually can shock the heart if people go into an arrhythmia and prevent, a cardiac arrest. So while Dad was in hospital, the team had decided to put one of these implantable devices in. Now, the thing is, we knew as a family that Dad didn't want to be resuscitated, right? Because of his dementia, and that was his choice. Okay, so everybody has a right to a choice, and not everybody would make the same choice in those circumstances. But he decided he wanted to take his chances with his heart condition. Even though the evidence-based medicine pathway says, well, you should have an implantable device now. And we were able to have a conversation supporting Dad with the Professor of Cardiology in Leeds to make an informed decision that he did not want that implantable device for the reasons that he had said. And so he didn't have that device. And 8 months later, he indeed did have a cardiac arrest and died. Now, for Dad, that was a good result, because we had adhered to his wishes, and he took his chances with his heart. He had 8 good months, and had he had that implantable device, potentially he might have survived that arrhythmia that ultimately killed him. He may not have, but he may have survived that, and he may have continued, well, he would have continued on with his cognitive decline, and that is not what he wanted to happen. So the lesson from this to me was not, you shouldn't offer anybody with dementia an implantable device. That isn't what we're saying at all. The lesson from me with that was, how often do we accidentally push somebody down an evidence-based pathway without actually giving them the opportunity to understand the implications of that choice? And how do we personalise care truly and undertake shared goal setting and shared decision making truly with our patients? Because that's when we're going to get the best outcome for every individual in their own context, not just at a population-based, evidence-based pathway approach. So those 2 examples really led me into thinking that value-based healthcare with a person-centered approach to what matters to individuals, coupled with a population approach to how we best allocate resource to meet as many needs as possible, particularly focusing where we're struggling to invest. Those 2 things really made me completely committed that this is the right way to do things and the right lens through which we should look at the system, whether we choose to call it value-based healthcare or not. I'm not even, I haven't drunk the Kool-Aid of Michael Porter in Harvard University. There are tools for different jobs, but I think the ethos and what we're trying to achieve here in Wales is incredibly important. So that's the end of my first section, Nick and Dave, and I suppose I'm going to be cheeky now because I know I'm going to get loads of questions, so I'm going to get in with a question first, which is that's why I'm interested in it. Why are you, and why did you want to do this value-based healthcare cast?
You've turned the tables. Well, for me, I suppose the 2 things were that as someone who delivers frontline care in the NHS, I just quite often see examples around me of what's not going well, or where patients end up in the wrong place at the wrong time, and the effect that has on them, but on the system as a whole. So I've always been interested in how to make systems better. And part of that for me is listening to patients and figuring out what their needs are by listening to them, and what the expectations and needs and wants are. And that led me into looking at patient-related outcomes. But I found a lot of the conversations around PROMs were very technical. What platform should we use? How should we use technology to make things better? And that wasn't really adding up for me. So I really wanted to learn a bit more about value in its truest sense. And I think probably that led me on to conversations with you, Sally, and we thought, well, if I'm having those questions and the bits are not quite adding up for me, then probably a lot of people in my position and Nick's position are asking the same questions. So probably there's a need for us to actually learn more together and share that learning, and hence, you know, here we are today doing our health cast. But Nick, how was the journey for you? How have you ended up here?
Yeah, I guess it's reasons why I ended up in rheumatology. So I can think of a couple of kids. There was one as a trainee where there was a kid with systemic onset JIA. So this is arthritis with fevers and rashes, and there was no treatment at that time for this child, and there was no charity support for them. There was no really thinking about how do we support this kid at home, and yet in the bed next to them was a cancer, where there were loads of charities to support. This kid had been off on various holidays and everything. And I know that the outcomes are different, although there's fantastic outcomes for leukemia these days. This kid was playing with loads of toys, whereas the kid I was looking after had just the one toy. And I thought, well, there's a remarkable inequity here, not just in treatment, but in the way that we care for these kids. And so that's what drew me into rheumatology. I was lucky enough then to get involved with a technical solution for that, which is a new drug. And I did the first study of tocilizumab with that. And I thought, well, that's great. But then how do they get hold of the drugs? And then where's this patient different than, say, from someone who has chronic pain, where they're not at school 80% of the time and really struggling? And we have this other patient where I've been trying to get the right sort of therapy support for this girl. She was on our waiting list. We'd seen her. We needed to get the resource to provide support for her. And yet we had 2 patients come for a new surgical procedure. So they're both at university. This kid wasn't even at school. And they were being offered the very latest in surgical procedures. And yet we still didn't have this inequity. And it was just thinking, well, I'm providing holistic care for those in front of me, but who am I missing? And why are we missing those? And then we know that patients live with a condition 24/7, and we see them for 15 minutes, 30 minutes, maybe every 3 months. And the patients are complaining about access to the drugs. And so it just seemed to me that there needs to be a system redesign. And so that's really how I've then approached it and thought about integrated care, about how do I reach out beyond just my organization. And obviously there are battles in trying to do something different from the NHS face-to-face. But they're sort of battles that I've been happy to take on. And then you think, well, actually, no, we all need to be thinking this way, because then it makes it all easier for everybody. And then it just thought, well, I've got to come to Wales then, because that's where they're doing it best. And so unfortunately, that's why you've got me.
Well, croeso. We're very, very happy to have you in Wales, Nick. Well, that sort of takes us on nicely to the next section, I think, doesn't it? Where we get into a little bit more technical detail about what we mean around whole pathway design and the sorts of things that increase value across the whole system, because it is about reducing inequalities. It is about improving outcomes and experiences for every individual. But it also is about managing our resources really wisely, isn't it? So let's get into that. Unless there are any questions you want to field from the audience before I move on.
Well, it might be helpful, Sally, just because in case there was anybody joining late, for us just to recap
I think it's a good
what
idea.
we've been talking about. Yeah. So first of all, welcome everybody if you just joined us. This is the Value-Based Health Cast, brought to you by the Wales Value and Health Centre. Today's session is called Back to Basics, and our guest is Professor Sally Lewis, who heads up the value-based healthcare work in Wales. Sally's just taken us a bit of a whistle-stop tour about her journey in value and what value means to Wales. And we're just about to jump into the second part of Sally's presentation. So Sally, I'll hand back over to you.
Lovely, yeah, thanks for that recap. So we've covered the hearts and minds bit, I hope, and culturally why this is important. So now to go into a little bit more detail about what we mean about delivering value in healthcare. So to get true value in healthcare for a group of people, patients with similar needs, we need to look at the sum of all interventions across a whole pathway. So from a chronic disease, that means prevention right through to end of life, and understanding the outcomes and the costs of delivering healthcare that supports the achievement of those outcomes across that whole pathway. So that means prevention, looking at early accurate diagnosis, lots of work around optimizing intervention, and of course quality improvement comes into that as well. How we design supportive treatment, even down to the detail of how many follow-ups people really need. How many do they really need? Because a lot of that is professionally driven, not driven by patients. And then how do we deliver excellent palliative and end-of-life care when that becomes the issue? So when you think about what we need to do to improve outcomes, of course, it's not just about healthcare. In fact, I think the percentage of people's health that is delivered by healthcare is quoted as being about 20%. So actually, a lot of health is generated by other things, that are outside healthcare, such as obviously food, good housing, good relationships, all of those things about life that make us healthy. But when people start requiring care from us, in order to be able to get the most out of their healthcare, they need to understand how to navigate the system and how to play their part in getting the most out of their treatments. So we call that health literacy, but it is something which we all need support with, and that's why I made the case for supported self-management very strongly early on in the presentation. So we need to think about that. We also need to think, building on that self-management theme, how we support, yes, healthy behaviours towards prevention. So what is it that we need to do around the obesity and type 2 diabetes crisis, for example? But very importantly for me, how we support people's optimisation of quality of life when something's already gone wrong is equally as important. So that kind of secondary prevention, if you like, and also optimisation sort of rolled into one. So in Wales, we've really started to shift health policy on that and have started to see through the Value in Health programme investment where it's been really tricky to get investment before, such as strategies and interventions to reverse type 2 diabetes, alcohol liaison services to scoop up people who are beginning to have issues with alcohol misuse before it's really created very severe adverse outcomes, but diverting people into support earlier on, early intervention essentially, and we've struggled to do that before. So that's a real green shoot of progress, and of course helping people to understand medicine and their choices, going back to the example of my dad and whether he should or shouldn't have an implantable device for his heart failure. On the healthcare side, we need to understand how to finance for value and how we optimally allocate and prioritise resources. So the Finance Delivery Unit in Wales are doing fantastic work on this, actually, working with health boards to see how we drive that, because health boards are £1 billion organisations. They have huge budgets, but still huge pressures. So how do we construct that resource allocation that gives us the wriggle room to try new things and new models of care, and also tackle some of these neglected areas in the past, one of which you highlighted, Nick, just now. Decreasing unwarranted variation and low value care. So as clinicians, we have to have a degree of self-awareness and challenge ourselves too, because I think we have a responsibility of stewardship to really critically appraise everything that we do, that we imagine is the right thing, and often it is, but we need to have that self-awareness that we can always improve in our service, and we need to collaborate across the system with other clinical professionals and operational and financial managers and informaticians to think about how we transform that whole system of care. And that means looking up and out at other services as well. So if we're a hospital consultant, thinking about what's happening in the community and vice versa, and not lobbing stones at each other, which sometimes happens. Optimum positioning of drugs and devices. Again, that relates back to Dad's example a little bit, doesn't it? So a lot of the medicines, especially the high cost medicines and devices and surgeries that we use, are amazing technologies and massively improve outcomes in the right context with the right support wrap around them. But we don't just see underuse, we see overuse, and we see suboptimal use. So there's a lot of work in value around how we do that. New models of care I've mentioned. Digital health has a big role to play, but that's evolving monthly and has been accelerated through COVID, as we know. And we need to make sure that we don't imagine that's the panacea, but we make sure that is supporting care processes, supporting clinicians and people receiving care, not creating another unintended consequence. And of course, we need data. So we need clinical data, clinical outcome data, and we'll probably can pick that up in the chat, how we get that, and also patient-reported data, patient outcome and experience data, and understanding that in relation to the usual administrative and costing data that we see within the system, to use that as intelligence for value so that we can create a data-driven decision-making in the system. People on the call who are not working in healthcare might imagine that that's what happens anyway. Unfortunately, that isn't what has happened. There have been many other drivers for healthcare, but generally speaking, outcome data has not been one of them, and that's the culture that we are shifting in Wales, which I think is really important, because that not only is that going to improve outcomes generally for people as a whole across multiple condition areas, but it's going to help us focus on meeting that true unmet need, the people we're not seeing, Nick, that you just were talking about, and reducing health inequities. So that's kind of a broad overview. So getting into now a specific example that health board teams have been working on, because we have a value and health team now in all of the health boards in Wales, which is fantastic, which we work in partnership with. And our role is not to tell them what to do. Our role is to work collaboratively and try to move obstacles out of their way, essentially. So let's go through the pathway and see what's been done. So at a prevention level, well, if you're preventing heart failure, this is the example that we're talking about here, of course you need to prevent heart disease. So primary prevention, smoking cessation, alcohol, healthy alcohol use and so on is of course important, but there are other things going on in the system that also contribute to burden of disease in this area. So if you have a heart attack, you go onto the acute coronary syndrome pathway, which describes optimum management of people who have a heart attack, which includes certain time points along that journey that need to be met. If you don't have a well-performing ACS pathway, you're going to have a higher incidence of heart failure, arguably, or certainly poorer outcomes in terms of people's cardiac status after their heart attack. So improvements in the ACS pathway are absolutely part of what value looks like in preventing heart failure. And we see lots of linkages like that across and interdependencies across the system. Then into earlier accurate diagnosis. So to diagnose heart failure, as you know, we need an echocardiography a scan of the heart. That's the gold standard in diagnosis. But echo is it's a costly, and it's not just about financial costs. Actually, it's about workforce. So we have scarcity in the workforce. So it means access to echo has sometimes been difficult, and people have had to wait a long time for their echo, up to 9 months, which clearly is a long period of time to be poorly, and people get more poorly and get admitted to hospital. So it's bad for people, it's bad for the system. We can screen out some people who would have been referred for echo with a simple blood test. And Swansea have done a fantastic piece of work around this, where they have hugely reduced the waiting time for echocardiogram from what I think was initially about 9 months down to weeks. So access has hugely improved, diagnosis has improved. That means time to optimization has improved, outcomes are better. Moving on into optimizing intervention. In heart failure, initially that means timely titration of medication. So getting people onto the optimum medication, which you can't do immediately in heart failure. It takes a number of steps and a period of weeks, sometimes a couple of months to do that. Previously, we've seen people actually not become optimized or have a very long period of time to optimization for various reasons. Now, the Honorary and Bevan Health Board community heart failure nurse service has done amazing work at using patient-reported outcomes and clinically reported outcomes to guide how they follow up patients. So they are providing intensive intervention for a group of patients that need it, less intensive intervention for those that need less. And the impact of that has been that they have reduced their 30-day readmission rates to hospital for heart failure to 0. An absolutely stunning result, the last time I looked at the results. But they had hugely improved outcomes, essentially, without needing a lot of other investment. So we don't always need to pour lots of new money into a service. There are things we can do to reimagine the way we deliver healthcare with our patients that is high value. And then in Cardiff, we have seen a fantastic development in palliative care services for those with heart failure. We know that people with non-malignant disease have poorer access to palliative care because it can be more difficult to recognise that they are moving into that phase of their disease. So that was a true collaboration between palliative care and cardiology, which is now being expanded into renal and liver disease as well. So each board has done an exemplary piece of work at one step of the pathway. So we now kind of know what high value care looks like for heart failure in Wales. And now the job is to knit together all of those elements so that all boards do all elements over a period of time. And we would like to see this approach replicated, and we are indeed replicating it for other clinical areas as well. And we should be able to, sorry.
It might be a good opportunity, actually. There's a lot in that one slide. There's a massive amount, isn't there? It spans the country in terms of all the different work underway. But just recapping under some of the themes that you've covered in this section, talked quite a lot about patients and patient-centeredness and patient self-care. Mm-hmm. And that was one of the themes that Lisa Thomas Emrys talked about in our previous value-based healthcast as well. And I was just wondering, it was just a question on that. It seems to me that we've actually, maybe through the success of the NHS, we've actually decoupled people from their own outcomes in many ways, and from the, decouple them from health and healthcare. And how do you see us bringing that back? In terms of bringing the patient back to the centre of the conversation?
Yeah, I wonder whether we have over-egged our abilities, really. I mean, we've done a brilliant job of increasingly rescuing people over the last 20 years, which is, of course, fantastic. But there are often, you know, people are left with symptoms, and people need support, and therefore I think there's a responsibility for the healthcare system to coach people, support people in what it means to live with a chronic condition, for example, and also to do far more in the prevention space. But I think that support and coaching for living with is the really pressing thing. And I know Lisa's done amazing work on her WISE programme, and that's exactly the type of approach that we need to grow. It doesn't mean to say that we shouldn't be doing all of our technical interventions as well. Of course, it doesn't mean that, but we do need to be working with patients, not just doing to patients, perhaps in the way that we have done historically. And of course, and the last point to make about this pathway is, I know many people are interested in the green agenda, in the carbon agenda, which is also about reducing consumption, isn't it? So it's very much linked to carbon footprinting and sustainable quality improvement as well. So if you're not interested in everything we've talked about so far, maybe carbon reduction is the thing that floats your boat. All of this supports that agenda as well. But we've got to really think about, you know, what there's a lot of people living with chronic conditions in Wales, and we need to think about how to support them far better than we currently do.
Thanks, Sally. And so one of the things that comes across from your talk, and it might be perceived by the audience that this is all quite high level stuff, is that it's at health boards and health boards connecting. And what you point out in your paper, which I think was brilliant, was that patients, clinicians, organisations, and organisations being hospitals, GP practices, and broader organisations, charities, that we've all got our responsibility to this. And I just wondered how do we get patients engaged with this? How do we get staff more engaged with this?
Yeah, so everybody has a responsibility in this, I think. So I'll try and structure it, because we've kind of touched on quite a lot of the issues in an unstructured way, but I think it's helpful to think about this at a sort of micro, meso and macro level. So the micro level would be the level of the consultation, so the conversations that we're having with patients, and you know, our responsibility as clinicians around stewardship of the resources, around humility, that we need to understand the context of the person in front of us and take care to support them in making the best possible decisions. And then the organisation has a responsibility, therefore, to support patients and clinicians with the core conditions to do that, right? Because it takes a little bit of time, and that's time as a premium at the moment, and it also takes really good information on both sides. So at an individual level, that's what that might look like: true person-centred care and individual stewardship, thinking about what we're doing. At the meso level, that's about the pathway. So how do we collaborate across? And we're very lucky in Wales because we've got integrated health boards. So for us, collaboration is much easier than in many other healthcare systems around the world. We can very easily collaborate from public health, primary care, secondary care, tertiary care, to design this approach. And then, of course, working with finance to understand what that means in terms of resource allocation and so on. So that's the meso, that's the organisational, the clinical networks, you know, the delivery arm of this, if you see what I mean. And then at the macro level, we're talking about policy and enablers to support that middle layer.
There was a really shrewd question that came out from Lisa Thomas. talking about one of the challenges in wellness service is a lot of patients mentioned their apprehension of getting better because they will lose sort of a financial incentive, which is from the disability living allowance or whatever, or the PIP as it is now. So, you know, we're creating these situations where we're oiling the works in one way and then causing it to seize up in another. How do clinicians sort of get hold of this? What you know, where should we be working? What forums can patient staff bring these dilemmas to help them?
Yeah, and it's a great question, and it's an issue I've come across before in my own practice, and it highlights a real, you know, structural problem, doesn't it,
Yes.
with the system and the way we look at benefits, the way we look at maintaining people's health and well-being in communities. So again, going back to what I said earlier around thinking about the relationship between the consultation, the organisation and policy, you know, for me that is a massive issue to highlight back up to policy and start thinking about how we deal with the unintended consequences of other policies on health. You know, it's a really difficult problem, and I don't have of course, I don't have a solution to that today, but it absolutely highlights why this is everybody's responsibility and why we need to work from the bottom up and then back down again to try and resolve some of these real wicked issues.
Yeah, and I wonder actually, you know, Lisa's obviously describing one of the challenges she has. I'm pretty confident there's other people, even on the call today, who've had exactly that conversation with patients. And you know, one of what we hope to get with the HealthCast is actually that networking, that ability to share problems and challenges. So yes, if there is anybody on the call who has had exactly that problem, then you know, it'd be really interesting to if you pop something in the chat bar and say who you are and if you've had that experience yourself, because yeah, that's how we overcome these things and try to fix you know, every individual problem. Let's share that knowledge. So Sally, I wonder if actually, because we're now 15 minutes out, we've got 13 minutes to go. I wonder, can we squeeze a few quick fire questions in before we finish up? Some rapid fire stuff. Are you up for that?
Definitely up for that, but I do want to I'll skip over Atul Gawande then. Sorry, Atul. I just want to leave this up as a screensaver because, or maybe it'll be one of the questions that comes through, Dave, because we frequently get asked, or I get asked, well, you know, what do you do? What do you actually do in the Welsh Value in Health Centre? So I think that's quite important that people know what we do and how we can try and facilitate, enable some of the work that we'll be talking about, and also because I don't want people to think I'm twiddling my thumbs. So I'll leave this up as a screensaver.
So Sally, I've got a question, and actually what we'll do is we'll just recap for those who may have just joined the call. So welcome to everybody again. This is the Value-Based Healthcast, where we collaborate with Sally and the Value and Health team at Welsh in the Wales Value and Health Centre to talk about value and health and learn a bit about what's going on across Wales. So Sally, is value-based healthcare just for execs? I mean, it sounds quite strategic to me. Is this something which is that's the level we're talking about here?
So is it for execs? Yes. Is it just for execs? No. So I think we've already touched on the fact that this is everybody's responsibility, including patients and the public, in terms of how we improve our outcomes as the population of Wales, our health outcomes, and actually how we preserve. We clearly believe in the NHS in Wales and care free at the point of delivery, and we want that to continue, and therefore we have a collective responsibility to think about how we make that a sustainable offering for everybody, and we all have a responsibility in that. So we've talked about, you know, the consultation. So thinking about what we can do in person-centred care in the consultation. So clearly that's the application there. We've talked about service redesign. So if it's not bottom up, if clinicians and people receiving care are not generating the solutions and grabbing this by the horns, then no amount of top-down thinking from clever executive teams is going to resolve that. So it has to be a grassroots bottom-up movement, has to be. And I believe in Wales it is. I think it's becoming that way. We're starting to get a groundswell of work in this area. However, you then do need executive buy-in because if Welsh Government and policy levers aligned to what people on the ground are doing and finding the solutions for. Because if we don't have that top-down coming in to support the bottom-up, if that makes sense, then people meet unimaginable hurdles and they can't achieve what they want to achieve. And I know that you've both had experience of that in your own clinical worlds. So bottom-up, top-down, in my view, together.
Like the Channel Tunnel. So,
yes, indeed. Yeah, exactly like that. Yeah.
But one of the words that you've used a lot is stewardship, and the reason that I might be in that is because how do I get the funds that allow me to make the changes that will then produce a whole load of cost savings or greater impact? And that will then yield further savings. How does stewardship fit into that?
Yeah. So stewardship is hard, and a lot of colleagues get kind of annoyed, really annoyed with me actually when I talk about stewardship, particularly in the current context of our healthcare services. But I'm going to go back to the COPD example that I mentioned. So for those who joined the call late, I was talking about the treatment of chronic obstructive pulmonary disease, which is a very debilitating chronic respiratory condition for which the treatments are not particularly good. And in primary care, mostly inhalers. You know, we have historically anyway had a lack of investment in supported self-management, whether that's formal in terms of pulmonary rehabilitation or less formal in terms of third sector developed breathe easy groups, for example, which are kind of more community groups to support people with breathing problems. In some work that we did a number of years ago in South East Wales, we found that when we looked at prescribing variation data, we were over prescribing in COPD in a way that was very costly and not improving outcomes for our patients. Therefore, we put a multidisciplinary group together with patients in the room to devise a plan to rationalise prescribing. So that didn't mean cut prescribing, it meant rationalise it down to what other centres were doing. So outcomes of patients did not suffer, but we were able to save a lot of money each year, which we then secured buy-in from the finance community to reinvest in supported self-management strategies for people with breathing problems. That is stewardship at an organisational level in action, but it required individual clinicians to do the work on the ground with patients around that rationalisation. So that takes work. And I think as a clinician, you're only going to do that, you're going to get people's buy-in if they think they can influence something for the better, or that it's not that there's something in it for them necessarily, but that you're tapping into what matters instead of just being asked to contribute to the bottom line of the organisation, which, let's face it, is quite a soul-destroying task, and people get very jaded with that. Important though it is, financial managers on the call.
And that's a key part that we can all think of is, you know, should we prescribe that drug or this drug or this therapy or that therapy, you know, or the way that we talk. you know, with our patients. Did you have a?
Yeah, I totally agree. I do, and so just thinking back through all of the conversations we've had during the last hour, and looking at some of the questions coming in online, and Sally, what I'm going to do is I'm going to just get a couple of the questions, and you know, we've got 5 minutes left. We've probably got time for 3 or 4 questions, so real rapid fire stuff. Okay, so Graham Hunter from Pencoy Medical Centre says, he knows this is a general back to basics session, but is there somewhere I could look for possible learning or opportunities for primary care related value-based healthcare? So where does Graham go to learn more about value-based healthcare and primary care in Wales?
Okay, Graham, if you would like to get in touch either with me personally or via our generic email address, then I can signpost you to some colleagues who are working on this. There's also some excellent educational opportunities through the Intensive Learning Academy in Swansea University, which are often sponsored places for NHS Wales staff. So I think we can signpost you to both practical and theoretical aspects, depending on what you would like.
Great, thanks, Sally. So next one, right? So where do people go in organisations to get information about value in their health boards, or is this completely different in every health board across Wales?
No, there is now a value in health team in every health board across Wales. We have contacts for all of those teams. So again, if you would like to email our generic email address, which I think that Brooke has kindly put in the chat, we can give you a list of contacts depending on where you are.
And is there value in health part of the undergraduate curriculum?
So the short answer is yes, it's becoming part of the undergraduate curriculum slowly. So we have a little bit of it now in Swansea Graduate Entry Medicine. And it's coming into postgraduate CPD. We're beginning some work with HEIW. I have, there's lots of stuff in the postgraduate space, but we've got our toe in with the undergraduate curriculum. The difficulty we have there, I think, is not lack of interest. It's more that the undergraduate curricula are so busy already. It's how do you compete with all of the clinical teaching that needs to happen?
Because I don't think it's necessarily a competition, because it's about nuance. Because Rob Letchford, in his question, he points out that we use language with our, the people that we see. We call them patients, which in a way is subjugating rather than people. And we're not giving them necessarily procedures. We're pointing them to new ways of thinking. And so, it's then our communication strategies are very much wrapped up with value in health or value-based healthcare. And so we can then enter into communication strategies as part of this, don't you think?
Yeah, I completely agree with that. And that's been a fascinating piece of learning for me. And in fact, so much of this is cultural and behavioural for all of us, all of us in every context. So we can't communicate enough, and we can't challenge ourselves enough, really. It would be good to do a dedicated session on that, I think. It's so important that we even have a dedicated comms director now on the team, because getting that communication and engagement right is so important. But of course, it's also important in the consultation. So skilling people up with what we mean, this is a long-term endeavour, changing people's perceptions around what healthcare is and what our interrelation with it is. So there's a huge amount of highly philosophical and deeply cultural stuff to tackle too.
As well as, another thing was brought up here, Hayley has mentioned, well, how are we connecting with well-being of future generations, decarbonisation? I think you spoke to it already. I think we have to get involved with the other policy. But alas, we could just keep talking forever, couldn't we? And I think this has been a brilliant session. What do you think?
Yeah, fantastic. For me, just seeing the examples, the heart failure example of the pathway, and seeing all the work that's going on in different steps of the pathway in different parts of Wales. Wouldn't it be beautiful for heart failure or anything, take anything, take any part of healthcare to knit together, so we could share that learning. So we're not trying to reinvent the wheel in every health board in Wales. What about you, Nick? What's your take on?
Well, what I've liked in this session is again, it's, you know, people's healthcare conditions are often complex, and then the solutions that we need to find are often complex. And what you've not done is you've not shied away from that and sort of just broken it down into simple bite-sized pieces that at each level and then across each level we can think about. So it becomes a matrix, and which we can apply. And I think that's the way we need to think, rather than just reductive treatments. This is the thing I'm going to give and that's going to make you better, because we know that that's no longer the answer. So that's what I've learned from today.
Yeah. Well, Sally, thanks so much for taking the time to talk to us today and share sort of what's going on in value across Wales. It's been fantastic.
Thanks, guys. Well, I survived, and there's still people here, which is amazing. So thanks everyone for listening.
Oh, fantastic. So let's just wrapping it up, Nick. We know obviously there's been a lot of chat in the chat bar, and thank you for that. If we've got questions we haven't been able to get to today, we will endeavour to either get back to you or to post some of those questions and answers on the website. And we've got your email from the registration, so we'll be in touch. So from Nick and I.
Yeah, thanks guys. Thanks for tuning in. Thanks for your questions. We will try and feedback as best we can. And thanks, Sally. You know, and thanks for it all. Thanks.
Bye, everybody.
Bye all.